On behalf of PHA Canada, welcome to our webinar on pulmonary hypertension and transplant. I'd like to introduce our expert for today, Dr. John Granton, who's the head of respirology at the University Health Network, Mount Sinai Hospital, and Women's College Hospital, a consultant in respirology and critical care at Toronto General, and professor of medicine at the University of Toronto. He's the founding and ongoing director of the pulmonary hypertension program at the University Health Network. He is going to be interviewed today by PHA Canada's Director of Programs, Kimberly Brunell. We're happy he's been willing to have this conversation with us. So over to you, Kim and Dr. Granton.
Thanks so much, Robin. And yes, thank you so much, Dr. Granton, for being willing to spend the next hour with us. I really appreciate it.
No problem. Happy to be here. Thanks.
Thanks. And hi to everyone at home and joining us live today. Today will look a little bit different than our normal webinars. You'll notice that it's just Dr. Granton and I on the screen today. There are no presentations or slides. I have the pleasure of interviewing Dr. Granton today on all things transplant. I do plan to cover everything from, Dr. Granton plans to cover, I will just ask him the questions, everything from that initial transplant conversation all the way through to post-transplant. So as Robin mentioned, if you have questions, please post them in the chat or the Q&A, and we will leave plenty of time at the end for your questions. So Dr. Granton, let's get started because I have a lot of questions for you.
Sure.
So I like to start at the very beginning. So I am a patient who has been diagnosed with pulmonary hypertension. I come to see you at clinic. When in my PH journey might you have that initial conversation with me about the opportunity of having a transplant?
Okay. So that's an important question, and I think it varies. And it's not too early and it's not too late is the big answer. And certainly we recognize, the shock of being told you have pulmonary hypertension, and then, to launch into discussion around all treatment options, which would include transplantation, would be too overwhelming. So at some point early on, we usually mention that, and people most have read that transplantation is an option for people who have advanced disease that doesn't respond to medical therapies. So some people want to know right off the top that, do I need a transplant? And you answer that. The answer is, I don't know. And it depends how you respond to medical therapies in general. And so we kind of know that out the gate in some respects, that if you have a classic group 1 idiopathic pulmonary arterial hypertension, a true group 1 condition related to autoimmune disease, those sorts of things, we usually would say, well, we'll wait to see how therapy responds. But if you have more complex disease, if you have significant scarring or fibrosis or emphysema or other things that's driving the pulmonary hypertension, unfortunately, people are less likely to respond to medical therapies. And so we may have a conversation around transplant a bit sooner in those higher risk conditions. And that was brought forward in the most recent World Symposium guidelines that we were part of, and recognizing those high risk conditions and engaging in those conversations earlier. And sometimes people with very severe pulmonary hypertension, we have that conversation earlier as well, just in case something goes awry. They start to deteriorate despite medical therapies, and we need to do something. So sometimes we can move it up, but more often than not, we like to have a sense as to whether the medications are working and how well they're working, to see if they've responded both to how the care providers would like to see respond, but more importantly, how the person with the condition is responding, to make sure that it's meaningful and it's providing them with value in the true sense of the word. So.
I know that when you and I have had this conversation in the past a few times, you've talked to me before about the importance of having, for you, it's important to have this conversation early. How does that benefit the patient? And as a practitioner, why is it important to you?
Well, I think, again, I frame it much more as developing a safety net, talking about plan A, plan B, plan C. Just to let people know that we're there to support them through their entire journey, whether it go well or not well. And that, we're fortunate because we're a transplant center, so we're really close to the mothership of transplants. But it's very problematical if you're in a place which is maybe more isolated, doesn't have a transplant program. I think it's important to engage in those conversations sooner because it requires a lot of planning and referral and all that kind of stuff. And the other big thing about an earlier conversation about transplant is that it may require some lifestyle adjustments early on so that people, if they need it, can become a transplant candidate. And that could be, if they're deconditioned or their person's overweight, they have a high body mass index, they wouldn't be eligible for transplant if they're actively smoking or using non-prescribed medication or even prescribed medication beyond for which they're not indicated, have different addictions. All those things need to be addressed before we can discuss transplant because those things are kind of deal breakers for transplant. And so to make you the best you can be, essentially, just in case you need a transplant, so it's available as a backup.
That segues as well into the next portion. So we've had this conversation. I know that this is a possibility, and we've reached the point where we've decided that it's time to put transplant on the table.
Yeah.
And I have to go to the next step, which is getting assessed by the transplant team.
Yeah.
Can you walk us through who is part of that transplant team? Who is part of the assessment? How long might that assessment process take? And at the end of the day, what is the goal of the team? What do we want to learn as part of the assessment?
It's an important question. So this was part of the World Symposium, but we kind of divided into three phases. So the first one is a conversation, which can happen it doesn't have to be transplant center. It could be with your practitioner, you'd be a physician or nurse, just to talk about transplant again as this backup modality that we might explore if you need it, or at least have you assessed just in case you do need it. And then there's the formal referral for assessment. And again, that may be a educational session. So you would meet with the usually transplant physician or transplant coordinator, and you would learn about transplant, and they'd learn a little bit about you. So it's more of an introduction to that, so that you come armed with information, and maybe you can just consider it just in case you need it. There may be, again, some lifestyle things that you want to have addressed before you go out on that date together. So you want to kind of put things into context, and that also makes the assessment process much better, because then the next time you go beyond that kind of discovery phase, it might be an in-person meeting or a virtual meeting where you're meeting again another set of individuals. We're going to ask you a lot of questions and give you a lot of information. You've already heard some of that, and that's when we engage and determine whether we should go into a full assessment, which is a very involved process. So a full assessment, if both individuals, the patient, the person with the condition, and the family, and it's a village, so everybody is part of this process. We usually invite everybody's support network, so we also understand who they are and can they support the person, and do they have enough bandwidth to manage this. Decides to go through it, and so that would involve referral formally to the assessment team, and that assessment team is a large number of people. Not only the person you just met, but the coordinators, social workers, physiotherapists, occupational therapists, nutritionist, anesthesiologist, eventually the surgeon. You may or may not have to meet other individuals. If you have underlying liver disease, you would need to see a liver-related person. You have kidney disease, you would need to see one of our kidney people. You have heart disease, you need to see one of our heart doctors. Do they need a heart-lung transplant? Do they need a liver-lung transplant? Sometimes you need a kidney-lung transplant. So all those things are discussed. And then there's a lot of tests. Now, most of the tests you will have already had. They're blood tests. There's just a lot more of them. And they'd be asking the question, well, do you have anything else going on that's a problem? And you look at your immune system, any viral exposures, like hepatitis, HIV, those sorts of testings. They look at your blood type. They would look at your Are you sensitized by that? I mean, are often women who have had babies or people who have had transfusions are sensitized to what's in the blood of a potential donor. So you might react aggressively to a new lung. We can talk more about that later, but just to understand what your immune system's like. And then there was the usual sort of investigations to look at your lungs, your heart, your kidneys, to make sure there's no other conditions which would present a challenge or which would be a contraindication or a red flag for transplant. And that can involve a period of time. If you're living, like for Toronto, we serve many provinces. So, you know, if you're in the East Coast, we would do most of that virtually, and you'd have most of the investigations in your home. So only then would you have to fly for a visit and then be assessed in person. We usually like to see people in person at least once. And then you would complete the assessment process, hopefully have most of your questions addressed. We would have our questions addressed. And then we meet together as a team to talk about you. So we would talk about, you know, you, your support network. We get feedback from everybody you've met through that team. We review all your tests. And then there's a decision whether the person is good for listing, acceptable for listing, if there anything else that needs to be done before we consider listing, if they have a condition that we can transplant, are they ready? Is it too early? And then we kind of also assign, well, can they be transplanted off a breathing machine? Can they be transplanted off a heart-lung machine safely? Is it a double lung or a single lung? For pulmonary hypertension, it's always a double lung. Do they need a heart lung? That's very uncommon. And are there any special circumstances that need to be attended to at the time of transplant or after transplant? So it's a very involved discussion. And so then you get a phone call, say you're discussed, yes, no, maybe, and then eventually you would sign a consent if the decision is to go forward. And then you would meet the surgeon finally to talk about the transplant again, and they would get the surgical consent. They would also be approached for research as well, which is a critical part of what we do. You would be asked permission to participate in just collecting information or participating in one of the studies, which might manage the way your lungs are managed before they go in or the way you're managed after the lungs go in. So
It's great to
that's
hear
a
that.
lot of information, but anyways, yeah.
It's a lot, but that's good. People know what that assessment
Yeah.
process looks like. But it's good to hear that even if you live quite far from a transplant center, which, you know, most people do here in Canada, that you can do a lot of that remotely. And then, as you mentioned, just maybe have to come in one time during that assessment period. So that's great. And so what are so I've done all of this. We've decided by the end of this, the team has given me the green light that things are ready to go. What are the factors that might determine where I fall on the transplant list? So what might dictate either what my priority status or where I might fall?
So it really depends how sick you are, and also blood type, size, heart lung versus lung. And the reason for that is blood types matter because of how many people are on the list and how many active donors there are out there with that blood type. If you're very petite or if you're very big, it's hard to get a right size match. People ask, well, can my family donate? No, particularly for pulmonary hypertension, you can't do, you need full lungs. We don't have a live donor program for lungs. The other thing is, do you have underlying conditions? So underlying conditions, again, which would place you at high risk or high risk of deterioration, and what's your trajectory? So are you rapidly deteriorating, things are getting worse in a rapid pace, then we put you on a very high level on the wait list. If you are kind of grumbling along and fairly stable but have risks, then we would put you on kind of the lower intermediate category. We don't have the same listing scoring system that the US uses or Europe uses. We have only a three stage. The lungs come from all over Canada. We use lungs that a lot of people don't use. That doesn't mean because they're terrible lungs. It's just that we have ways of assessing them and making them a bit better. And we have a very seasoned program, so we take lungs from all over Canada and also the continental US. So there's a large pool of lungs. We have a very large pool. We have, as a result, rapidly moving wait list, and we do over 200 transplants a year now. So the Toronto's the largest transplant center in the world, and then in Canada, by default, we're the largest. But behind us is Edmonton, and then Vancouver, I would say, as far as volumes. Yeah.
So now, if I'm on the list, can I come on and off the list? Is there any reason why that might happen?
Um, yeah, I mean, if you leave the country for vacation or something, or if you get sick and you're admitted to hospital with a not other condition like an infection of your line, if you have intravenous infusion, or if you get a gallbladder attack and you have an infection or pneumonia, you would be put on a hold. Um, you change your mind, but it's not like, again, you have to commit. We commit to you, you have to commit to us. And so once you're committed, and the phone rings, you have to answer it and you have to come in. We're not going to come and get you and hold your prisoner and take your lungs out. But there that people get very nervous that you're not committed if you back out. People know you're nervous, and it's, again, back to this partnership and marriage. You're mostly sure it's the right person. You don't know until you try, but yeah, you have to try, and you have to be committed. You can't go up to the altar and back out. Yeah.
Not, hopefully not. So I'm on the list and now I'm waiting. What am I doing during this time? Because the
Yeah.
wait can be, I think I've heard you say before, the wait list, can often be around 6 months, but again, that probably varies where my priority status is. But what am I doing during that waiting time?
Yeah, it's going to be very frustrating for people. So it can be too long and too early. So some people, as soon as you sign, the ink's not even dry and you get a call. So that's too early. But I've seen people transplanted within a week or two, which is very fast, and I would say very distressing and hard. Again, but you're over a year and you're waiting, and also equally disruptive, particularly if your home is somewhere else, not Toronto, or and you're not within 2 hours or available to come to Toronto for the transplant. If you're coming from the East Coast, for example, you have to move close to Toronto. And when you're on the wait list, you're not sitting at home on the couch in front of the TV. You're living your life. You have to continue with regular visits to see us, physiotherapy. So you need to come down and see us, which is why there's the requisite for being close by, being assessed, being monitored, making sure you're continuing to undergo rehab, because we do this thing called prehabilitation instead of rehabilitation. So before your surgery, we're rehabilitating you, making you stronger so you can survive this thing called transplant, which can be a marathon. So we're training you for that procedure. And you're getting a lot of education, nutritional counseling, lifestyle modification, adjustments of your medications. So if you have pulmonary hypertension and you're from another city, you unfortunately inherit one of us in Toronto as your doctor. So you have to, you're followed by us for your pulmonary hypertension needs, with communication with your home team for any major decisions. So yeah, there's a lot of involvement in um, the kind of wait list. It's a very active phase, and that's the reason for moving. Now, some people graduate to kind of their own, physiotherapy if they can demonstrate they can do it locally. Like if you live in Ottawa, great center, they've got rehab, they can demonstrate that you're being followed. You can still be on the list and live somewhere further away. But it's generally, for most people, you have to live pretty within 2 hours of Toronto, and be able to come in and be seen. So it can be very disruptive. And that causes strife, both waiting for the transplant and then after the transplant, because you're still stuck with us as we assess your lung function and getting you in for physio and recovery and rehab. You just can't go back home and your doctor's there to look after you. It's pretty specialized care.
So I've been waiting and I do finally get the call, and I race in to Toronto to meet with you and the team. What happens next? How do you know if this is the right set of lungs for me?
For them, I would say half the time it's a false alarm. So a couple of you have come in because we call in somebody else as well, just as a backup in case there's a problem. So one of you is going to go home, and that's stressful as well. So you should be prepared for the fact that you're called off, and that could be because the lung wasn't working well. Maybe it was infected. Maybe it didn't look right when they were looking at it. and they didn't feel that it would provide value to you and be too risky. So it's often a good thing that you weren't transplanted. You can look at it that way. You're waiting for the golden egg. But it does cause stress for sure. But just knowing that people are really paying attention to the quality of the grafts and that people get is really important, I think, and key. But then you'll be told, yes, it's a go. And so you would meet the anesthetist again, you would meet the surgeon again, you would have some extra blood work done. They would probably ask you just to remind you about some of the studies you volunteered for, just to make sure you're okay with it still. And then you would go to the operating room and you would have your transplant.
Can you walk us through, in the simplest way that you can, what that procedure looks like?
Yeah. So you won't notice it, but it'll be it generally, it can be for a double lung transplant, usually 6 to 10 hours, depending on complexity. And there are nuances, but generally for our program, some programs differ. We do what's called a clamshell incision. So you put to sleep first, you're given an anesthetic, a breathing tube is put in. They put different intravenous catheters in to monitor you and give you fluids and drugs to support you through the surgery and keep you sedated and relaxed and free of pain. You're monitored. So you have a lot of monitors. You have an anesthetist and managing your breathing and circulation and blood pressure and all that stuff. And then you have a whole team of people in the operating room. You have 2 or 3 surgeons who are participating in the surgery, usually one staff physician, one very senior fellow, and another resident. And then a very seasoned team made up of a circulating nurse and other nurses, and a perfusionist in the room very often as well, who manages the heart-lung machine. So you got a lot of people. It's a crowded place. And that's a little intimidating when you roll in the room, you see all these people, but it's also should be very reassuring that team, like their sole focus is you. So they're just watching you, which is very cool. So you're given an anesthetic, yeah, and they make the incision, which is a clamshell incision, which kind of goes under you can't really see me, but it's under your breastbone, and it allows them to expose both sides of the lungs. We call this bilateral, which means both sides, sequential, which means one after the other, transplant. So the first lung to be taken out is usually the left lung. And then once that's removed, the first lung goes in, they attach the breathing passages, the artery, and the veins. They allow blood to go through that one, and then they go to the other side, take it out, connect the breathing passages, the arteries, and the veins, and then they allow the blood to go through. That sounds very straightforward, usually isn't. Often you have to go on a heart-lung machine at that time called ECMO, which is extracorporeal membrane oxygenation, which is essentially a pump that sucks blood without oxygen out, and then it pumps it back in under pressure to support not only your breathing, but also your heart function, because we've actually prevented some of the blood flow, and it tends to stress the heart a little bit. So we either do that just for the surgery. You may have already been on it to go to surgery if you're really sick, and you may wake up on it as well. So you may be supported after surgery on this ECMO machine. After the surgery, you aren't woken up. You are still anesthetized when you come back to the intensive care unit. You're still on a breathing machine, so there's a breathing tube in place. You still have a bunch of catheters and monitors in place in the larger veins in your neck or occasionally the leg. You're given a sedative, pain medication, and a bunch of other medication to suppress your immune system, and antibiotics to prevent any infection that almost always is in the lungs that were donated from causing problems until they get the final results of the cultures from those new lungs back. And that'll be tailored. You've got 2 drains on the right, 2 drains on the left to drain out any fluid or blood, and also to monitor to make sure there's no bleeding. That phase for people with pulmonary hypertension of being anesthetized and kept asleep lasts for about 2 to 3 days. Most people with lung transplant wake up or woken up pretty fast. For people with pulmonary hypertension, that doesn't happen. It's kind of like watching paint dry. You just don't touch it. Just leave it alone. It will dry, and you let them just kind of dry off for about 2 or 3 days. And that's just to allow that heart, which was so stressed, to kind of adapt to its new environment. Because any attempts at trying to push people doesn't isn't well received by the heart. It's really kind of finicky initially, and it doesn't react to stress very well at all. So we are very cautious in moving slowly, gradually removing the sedatives, letting you wake up and breathe on your own. And then we gradually let you breathe independently of the breathing machine you're attached to. We start reducing the medication that's supporting your blood pressure. And we just kind of walk through it very slowly over the next few days. So the ICU length of stay, the time you're in the intensive care unit, is longer on purpose for somebody who comes in for lung transplant for pulmonary hypertension.
Yeah, being woken up slowly, that sounds much more pleasant than just being,
Yeah,
forced to wake up very quickly and suddenly.
yeah.
Interesting. I have not heard the analogy of just watching paint dry. I like that, but it just, might as well just hang out and see how it
Well,
goes.
I don't yell at my residents, but I tell them, don't touch the paint.
Yeah,
Don't test, just
you
leave it
agree.
alone. Stop touching it. Just leave it alone.
Yeah, you just sometimes want to pick at that little bit
Yeah,
of
you do. You want to test
thing.
it. You keep on going
Yeah.
up. Just don't. No, don't even try. Don't even think
Okay.
about
We'll not forget that. Okay.
it.
So now that this has happened, how long might I expect to be in the hospital? You've talked a bit about how long now I'm in the ICU. I'm eventually going to obviously
Yeah.
get out of the ICU. How long might I be in the hospital
Yeah.
before I'm well enough to go home?
Yeah. So when I'm talking about perfection. So if you stay the course and things go well, you're in the ICU, asleep for about 3 days, gradually woken up over the next 3 days, the tubes then removed. So you're in the ICU, I would say realistic about 10 to 14 days for most people. And then you would have the breathing tube taken out. They would assess you a little bit longer. Then you would go down to the step down unit probably for another week. And then you go to the floor, regular floor, walking around doing things for another week and then go home.
Okay.
If you deviate from perfection, it's longer. So if you have problems with blood pressure, there's any bleeding, you're weak and it's hard to get off the breathing machine, your heart's not working well, your kidneys could be stressed and injured, you might require dialysis. Maybe you get an infection because the lungs that you received have a bacteria that needs to be treated longer, or the lungs get injured at the time that blood starts to go through them. We call that reperfusion injury, which means they were stored outside the body and then blood starts flowing through. That causes injury. That can be significant as well. So all those things can deviate you from perfection. So if any bumps along the way are going to increase the length of time that you're in the ICU, and in turn, and you're in the step down unit, you're in the hospital, and your recovery. So anything will slow you down. And I think that's the frustration. People, I don't think unless you go through it and your families go through it, you really, really, really understand what it is you've just signed up for.
Yeah, perfection sounds, based on what you've described, to be something
Yeah.
pretty difficult to achieve. Lots of things in your way.
Yeah, there are. But, I don't want to be, people always accuse me of saying, boy, oh boy, who would ever want to do this? But, you have to go into this understanding that you're trading your disease for another disease, which is the transplant. And, it's a big deal, huge investment for you and your family, which why it takes a village. And, there's a whole bunch of things you have to do later. Like you're on lots of medications, there'll be lots of complications. You're basically still a patient with a condition that you
A different
hope is going to be better than the condition you left,
kind,
which is giving you a better quality of life and a better length of life, free from being short of breath, allowing you to do things that you want to do. So most people, they look back, say, yeah, I'd do that again. So anyway.
right? So, luckily, all has gone well, and I've eventually made my way home.
Mhm.
I am certain it's probably not the last I'm going to see of you. How
Well, we'll
often?
be the last you see of us. So you
I moved
divorce
on.
your yeah, you
Whole new
divorce your
set of
pulmonary
people now.
hypertension team. Yeah, you now are married to the transplant team. So you really spend time with them. We see our patients, really thrilled to see them. in the waiting room when they're getting the breathing tests and things like that. But you're monitored like a hawk. So you get regular breathing tests to make sure your lung function's okay, blood tests to make sure nothing goofy's going on, CT scans, bronchoscopies looking down to make sure there's no infection or rejection of the little biopsies done. And that happens at 3 months, 6 months, 9 months, year and a half, and 2 years, and then yearly thereafter. Some of that stuff can be done virtually. Like there are satellite programs that people can do that, and we just connect virtually. But for the most part, you come back to us and we do those tests, and you meet the team again and go through all those procedures. It takes a day and a half to do all that. But yeah, so you're still pretty tethered to us, and just good and bad. If anything happens to you, people are right on the phone asking us questions, and we try our very best to get you here to look after you as well. So you really have a committed group to your welfare and your life, and making sure that you have the best opportunity for a full recovery and a long life after a transplant.
Speaking of that sort of long-term success with transplant, what are or is the biggest threat, in your opinion, to long-term success with transplant?
Again, a great question. So the main things early on are infection and rejection of the lungs, which requires antibiotics, increasing your immune suppressants, which are usually things that are suppressing your immune system and preventing them from attacking the new lungs, because they're somebody else's lungs. You're forever going to be trying to get rid of them for the rest of your life. So you have to go up on prednisone, which has a lot of problems for people who have been on prednisone for a length of time. It can cause changes in mood, makes you hungry, makes you eat, makes you put on weight, gives you thin skin, high blood pressure, cataracts, diabetes, all those sorts of not so good things. There's other medications which can injure your kidneys, give you a fine tremor, can also affect your immune system. So those things are big deals. And that effect on your immune system exposes you to the risk of infections, exposes you to the risk of cancers as well, because your immune system is integral to really fighting off cancers. We're all fighting off cancers every day, and the only way we can do that is with our immune system. And if you suppress your immune system, that cancer surveillance system kind of goes a bit wonky, so you can get cancers as well. But the Achilles heel, the biggest deal for transplant survival and long-term recovery, is what we call chronic or long-term rejection. And that comes in different forms, but basically it's the injury to the lung over time from your immune system trying to get rid of those lungs. And to date, that remains the most common cause of disability and death after transplant, is chronic lung allograft dysfunction, we call it, or CLAD. Cute name for not a great condition. So.
And what is the average life expectancy post-transplant?
For pulmonary hypertension, if you look at how people do after transplant, it's a bit bumpier because of all the technical things that I outlined. So the initial survival is a little bit worse than other reasons for transplant, but over time they do the best. We don't transplant a lot of people with cystic fibrosis anymore. It used to be the very best because they were mostly young. So age is a factor, but you tend to do better than your peers who have COPD or pulmonary fibrosis or other things. That probably is related to the fact that you're younger for the most part than those other individuals who tend to be a bit older. So it's still not a panacea by any means. So when we're talking survival on average is about 7.5 to 8 years after transplant for pulmonary hypertension. But that's not everybody. You don't have this mortality clock that you're ticking down. You could live longer than that. I'd still bump into people 20 years out who are still after a transplant. But sadly, I don't bump into people even after 2 years. So some people have a very short life after transplant, and they really had a terrible time. But for the most part, people do pretty well. And like I say, you ask them, and they say, "Would you do this again?" I said, "Yeah. I got to do a lot of stuff that I couldn't do." So
yeah,
there's two things transplant offers, and that really is not only living a bit longer, but living better, which is really what our goal is, and most people's, I think.
Yeah. I want to get to some of the questions that I know the audience might have, but I do want to leave with a closing question for you, Dr. Granton. And when we talked a couple of months ago, you said to me in that conversation that the landscape of transplant is very exciting right now.
Mhm.
Um, as we close, I'd like to ask if you can share with us what that means to you. What innovations in science and research are upcoming that are exciting and might impact us in the PH community?
Yeah. Well, I think what we have realized is that the number of lungs of it being made available is in large part because we're able to, we have a very high risk tolerance, and we're also able to assess lungs, which other programs have looked at and said, no, they're not good. And we put them on lungs in a box. We put them on a breathing machine before they go in the person, and we put a solution through them to see how they work and how they perform. And we can look for infection. We can potentially do uh, uh, treatments of the lungs. Maybe we can do gene manipulation. We're now making universal lungs, donor lungs. We're stripping off all those things that make it unique for the individual so that they'll escape detection by the immune system. Um, we're using what's called CRISPR technology to do gene transfer to make them work better, blocking different things. So that's a huge deal. And we're now, even people who are donors who have hepatitis C infection, we can we can eliminate the hepatitis C mostly, and we can treat the hepatitis C if the recipient does get the hepatitis C. So there's a huge opportunity for the number of lungs being made available, which is great. The other really cool thing is that you can use maybe that same technology to eventually treat pulmonary hypertension. So imagine we can take your lungs out before transplant and treat them and do gene transfer of your own lungs and put them back in you. So there's a lot of cool things that are coming down the pipeline potentially because of that kind of technology. But the other things are supporting the individual after surgery on different sort of heart-lung supports and other things, which have improved the outcomes after transplant and helped those sort of initial I would say technical issues and blood pressure issues that used to cause a lot of problems. We've been able to soften the landing, as it will, after transplant so that people can get through it and do better afterwards. So yeah, it's very cool time.
Cool.
Yeah.
It is a very exciting time. Thank you. I have loads more questions, but Robin, I realize I can see the questions popping in, so maybe I'll pause my questions. Robin, can you help us with the Q&A?
And hi to everybody on the line. I can see a lot of people I know quite well. So
Yep.
hi, guys.
Okay, the first question is from Kathy, and it is there an age limit when you're being considered for transplant?
Not
I assume in
strictly.
both directions.
Yeah, not well, no, not so young. Like that's a technical issue, but for the most part, infants don't need transplant, at least lung transplant. They need maybe organ, liver transplants. Um, Lung transplants that we do in children. Um, the trouble is, as we age, it's kind of like an older car, looks good on the outside, but once you start, that little rust patch, you start sanding it down is actually a big hole. So I think it's what you uncover during that assessment process in an older individual, in a higher risk surgery, or those things that I outlined makes a person not a candidate. And by that I mean we're willing to take risks, but we can actually make your life more miserable by trying to do the transplant. We can actually rob people of time with their families and put them through hell and back. So it's not that we're not afraid of taking risks, or understand you may say, well, that's, you know, yeah, why can't I just decide to take that risk? We also have a responsibility to people also on the wait list and those organs, but also we recognize as physicians, we have limitations in our ability to do things, and we have to be realistic with people that things won't go well, and things may actually cause harm if we try to do them. So to be responsible that way. So it's not so much age. We tend to be less tolerant to older age and for pulmonary hypertension, though, just because the recipients have to be in much better shape to do well after transplant.
I feel I myself am full of rust patches, but there we are.
Yeah.
So, the next questions are both about um, things that might prevent someone from being a candidate. So somebody asks, what are the circumstances where someone is not a candidate for transplant, and can that change? And then along with that, are there co-conditions that prevent someone from being approved for transplant? So it's all
Yeah,
kind of one big
yeah, for
question
sure.
about candidacy.
Yeah, I would say again, not to be seeing it as being ageist, but advanced age or advanced weight or body mass index. There's a very strong correlation between outcome and body mass index. So you have to get your weight down to a certain level, ideally a body mass index of 32 or less. So if you're overweight, you won't be a transplant candidate. Severe deconditioning, well, that means being out of shape. Extreme frailty, which also kind of builds into that, instability. If you're smoking, anything. Substance use, using, amphetamines, methamphetamines, even narcotics, um, alcohol, other organs which are failed, kidney failure, liver failure, people with severe valve heart disease, like that need valve replacements or bypass surgery sometimes are just too high risk when you start adding these things up. Cancer diagnosis would invalidate you because, again, if you had a cancer and you started immune suppressants therapy, it would just explode. It would spread very, very quickly. So you have to be cancer free for a period of time, and we would deal with your oncologist to sort out what that looked like. Some cancers are very curable and only need a couple of years surveillance or 5 years surveillance. Some you're never considered cancer free when you start immune suppressants. Some infections that if you're active, like HIV, if you have active HIV and a high viral load or whatever, sometimes that wouldn't be into contraindication, but HIV is not an absolute contraindication for transplant. But the cancer diagnosis is a deal breaker, and smoking is a deal breaker, and high BMI is a deal breaker. The other deal breaker is, I would say, adherence to medical therapy. Showing up for clinics, taking your medications, understanding what you're taking. So you have to have played ball really well with your current treatments and treatment plan, and making sure you're following up and you're coming to visits. Again, transplant's a gift from somebody else, and so we respect that gift. And so the people that we give the gift to also have to respect that. The final one would be your support network. So you can't be an orphan.
Mm.
You need a really robust support network. And I mean orphan as far as you're the only person and you're living in isolation, which we see. It's really sad. Like we'll have somebody come from another country who has nobody, and they can't cobble together the support network to support them through transplant. So
That would be a sad thing.
it is sad.
Um, yeah. A question from Jane. There's often talk about finding the right timing with transplant, not too soon, but not too late. If things are getting late in the game, can a patient be saved and placed on ECMO until lungs arrive? And if so, how long can someone live on ECMO? And do you lose a significant amount of weight while waiting on ECMO?
Yeah. So yes, Jane, yes, that's true. It does give us a bit of buffer. We don't like using that as a backstop because it does cause problems. So you have to be on a special type of ECMO, which takes over not only providing oxygen, but also supporting your heart and circulation. We call that veno-arterial ECMO. So it takes the blood out of the vein and pushes it back in an artery. And that can have a lot of complications like stroke and bleeding and injury to the leg where the cannulas or the cannulas, by cannulas, I mean those big IVs come back into your body. So that can cause problems. We don't like to see people on ECMO ideally more than a couple of weeks, because things start to get a bit wobbly after that. People start getting complications. As you said, they start getting out of shape. And ideally, we like to see people transplanted earlier. Having said that, we still have outcomes, but they're like, to my earlier point, they don't uh, sail through smoothly. There's a lot more bumps the longer you're on ECMO before transplant. You would often come out on ECMO after transplant, and your recovery time is much, much longer coming in on ECMO. So it's not something we aspire to, and the French have demonstrated this very nicely in their registry data, that while you do pretty well on ECMO, almost as good as people not on ECMO, but that's because if they're only on ECMO for a short period of time. If you start extending that out, then the outcomes start to deteriorate. So
Hmm.
yeah.
That's everything from the Q&A box right now. Feel free, people, to keep putting questions in if you'd like. But I guess we can, Kim, it's back over to you for some of your questions because I know you have a list.
So many. You know what? I might just ask one more, Dr. Granton. Last time you and I talked, we talked about whether there has been an increase or a decrease in a number of transplants in the PH community over the decades that we've seen new treatments come to market. And I wondered if you could maybe rehash that response that you and I had the last time we talked about this. I think we talked about the fact that it's not that there's more or less, but that treatments that we have now are giving us better quality of life over longer periods of time. So
Yeah.
perhaps just delaying the inevitable.
Yeah, I mean, it's a great point. We don't know yet. So let's, call it out. So sotatercept, for example. So in the Zenith trial, which looked at sotatercept in really sicker patients, there seemed to be a signal on survival and reduction in transplant need, which was interesting. I mean, the question we don't know, are you just delaying it? Or are you actually making people better to the point that they won't ever need it? I don't think we know that. I mean, transplant for pulmonary hypertension in the broader pulmonary transplant era is it's not a common thing. We, as a big program, we maybe do 5 or up to 10 transplants for pulmonary hypertension a year. So it's a small percentage of the total transplants we do. It's and again, I think it's part of that may be the candidate eligibility, but relative to other conditions, it's less common. And as a result, it's harder to measure those kinds of effects you're asking about to see, well, what happens to this as the number of transplants. I do think that even when we started to see, the tablet medications that come through, and then we saw, we had Flolan well before that even. We did see that improve. It took people who would have otherwise been transplanted off the list for a period of time, a long period of time. So for sure, for those individual patients, it's easy to say that, and I was there when I started practicing, young women would come in, and the only thing you can do if they weren't a calcium channel blocker responder is transplant them. And the nurses were devastated, the families were devastated, everybody was dead, patients were lost. It was just devastating. The nurses were all hated the pulmonary hypertension. Now they come in and they have some of the old guard that were there and the senior nurses, and they remember. And they say, boy, things have changed. You see people come in and they walk out the front door of the building, which is just fantastic. So for sure, we've made a difference. That started to show in a clinical trial, but we all know we've done it, we've seen it. But eventually, sadly, for many people, it does progress. At some point, it comes back, or if this medication stop. I don't think they stop working, but maybe there's just ongoing injury and whatever. And people still require transplant as that backstop. So that's why we have to continue following, why we're so obsessed about doing those walk tests and the BNPs and the questionnaires and listening to your stories about how you're doing. And it's also the reason why you should be honest with us so that we can invoke that opportunity if it's required. So.
Robin, any others, or should we wrap up? I think you're muted, but I think you said we're good to go.
Okay, great.
I was indeed muted. Of course, somebody has to do it at least once during a webinar, right?
Thank
Yes,
you
we
so
can
much.
we can end up.
Dr. Granton, really appreciate your time. Thanks all of you who came to join us today. As always, we do record these and we'll make them available on our YouTube channel in some time from now. So thank you, Dr. Granton. Thank you, Robin.
Good to see you guys.
Everyone.
Okay.
Have a good
See
day.
the opportunity. Nice to see you all.
Bye, everyone.
Bye.